The broadcast is now starting. All attendees are in listen-only mode.
Well, hello and welcome to our webinar. It is the top of the hour, so let's go ahead and get started. Thank you so much for joining us on this webinar today so that we can focus together on the accuracy and precision of patient PICC tip placement. I am Emily Eberly, and I'll be your behind-the-scenes webinar producer. And I'll be processing and sorting all of your incoming questions from everyone in the audience, which we will answer during our live Q&A session during the last 10 minutes or so of the webinar. And now, I would like to introduce you to Rita Larson. She is our Vascular Marketing Clinical Specialist at Teleflex, and she will be your moderator today. Rita, I've enjoyed working with you as we prepared for this event together, and now I'm passing the ball to you.
Hi, Emily. Thank you for the warm welcome. I appreciate it very much. It's been my pleasure to work with you also. Good afternoon, everyone. My name is Rita Larson, and I am a clinical specialist at Teleflex Medical. Following our presentation, we welcome your questions. Please enter questions on the questions section of the GoToWebinar panel. You may do this at any time during the presentation. However, we will only take and answer the questions at the end of the session. This webinar is accredited for 1 contact hour for nurses and respiratory therapists. At the end of this webinar, you can obtain 1 contact hour by going to www.saxtesting.com/VH. Complete the post-test and evaluation form. Upon successful submission, you will be able to print out your certificate of completion. The provider, SACS Communications, is approved by the California Board of Registered Nursing Provider number 14477. During this webinar, no off-label use will be discussed in this presentation. The title of today's webinar is Implications of Precise Tip Placement Towards a New Gold Standard. Speaking on this very important topic is Ms. Nancy Moreau, CEO of PICC Excellence. Ms. Moreau is a highly sought-after speaker on peripherally inserted central catheters, PICCs, and issues of vascular access practice. Ms. Moreau began her nursing career in 1981 and is currently part of the PICC IV team at Greenville Memorial Hospital in Greenville, South Carolina. She provides educational consulting, program development, and speaker bureaus in conjunction with PICC Excellence. She is continuously involved with research and literature analysis and shares her expert opinion with PICC lines, ultrasound, and vascular access with manufacturers, hospitals, and individuals throughout the U.S. and abroad. Nancy wishes to disclose the following. She is a member of speaker bureaus for the following: 3M, Access Scientific, Angiodynamics, Teleflex Medical, Cook, and Excelsior. Nancy, we are delighted to have you present for us. We welcome you, and I give you the control. Thank you for joining us.
Thank you, Rita, and thank you, Emily. Hello, everyone. It is so great to have the opportunity to chat with each and every one of you about this very interesting subject. We're going to talk about implications of precise PICC tip location, the new gold standard in clinical practice. The objectives that we'll deal with today focus on evaluating the clinical practices and legal implications of tip positioning in order to achieve the most accurate and precise placement for PICC lines. We're going to talk about how all this applies to our practice, and more importantly, how it can implicate us in terms of legal liability. So when you think about PICC insertion and positioning, what is most important to you? And what are your legal concerns? I know that when I'm inserting a PICC line, first and foremost, I want to be successful with the access of the needle into the vein. But next, after that, and as I begin threading the catheter, I am very concerned with getting the catheter in the right place and completing it for a safe insertion. In order for us to all be successful, a large percentage of the time, we work towards having the greatest accuracy and precision. The terms accuracy and precision are sometimes used synonymously, but in fact they're quite different. The term accuracy means the degree of closeness or proximity to the true value, which means you can be highly accurate, getting kind of in the area, but have low precision, close but not at the point that you want to be. Whereas precision reflects the degree of reproducibility. How many times can you repeat hitting the same point over and over? You want high precision, but sometimes it's at a loss of low accuracy. All in the same area, but you really didn't hit the point exactly where you wanted to be. So how does all this apply to PICC line insertion? Well, we really need both accuracy and precision. Of course, we want to be successful. We want to put it in the right place, and we want to provide the patient everything that they need in order to deliver the medications and solutions. Ideally, with central venous catheter placement, we do achieve both accuracy and precision to place the terminal tip not only close to, but at the target area. Because really these days, close is just not good enough. Our target for placement of a PICC line is always the distal portion of the superior vena cava at the cavo-lateral junction. That is our focal point, and that's where we need to be every time. So when we look at the terms accuracy and precision, it points to the fact that anything other than our bullseye or our cavo-lateral junction is considered suboptimal tip placement. And when we don't put it in our target area, we have more problems. We have loads of research to support that. We have higher rates of thrombosis. We have lots of occlusion that interferes with our ability to deliver our solutions and treatments. We even have more infection with its relationship to thrombosis. Malpositioning occurs more commonly if the catheter is located higher in the SVC, and flipping can put the patient at risk by having infusates administer into the internal jugular or other areas where we frankly just don't want it to be. And so accuracy and precision is very important to us in order to deliver safe care specific to PICC lines. What are your goals with tip position and conformation? What are the things that you're trying to do? Well, we all want to make sure that we put them in veins and not arteries. A PICC is not supposed to go into an artery, and we certainly don't want to administer medications into an artery. And so a goal of tip conformation is to verify that it's in a vein. We want to reduce complications that might be associated with malpositioning or suboptimal tip placement. We also don't want more liability. We don't want problems that might result in legal lawsuits against us or the hospital. We want to put the catheter tip in a place where it has the highest flow, and that blood flow protects the walls of the veins, keeps the catheter from causing irritation or the medications or solution from irritating the vein. The blood flow picks it up and takes it right into the place that it needs to be. And so the last goal is to promote patient safety. So why do we want the distal tip of the PICC line near the cavo-lateral junction? Well, we have plenty of recommendations that tell us where the best location is, and one of the first ones was established by the Food and Drug Administration in their central venous catheter working group way back in 1994. Marcia Ryder and Dr. Walter Scott and many others were involved in this decision where they studied and determined that the best location for patient safety was the distal portion of the superior vena cava. Since then, manufacturers have included this as part of their recommendations for use of their devices. We also have it within our standards of practice with the Infusion Nurses Society, with the Royal College of Nursing, with the Association for Vascular Access in their position statement on tip position. Because of all of these recommendations, when we place the catheter at the correct location, our liability is reduced. And when we don't place it in the right position, it creates a situation where malpractice can be considered because it's not following the standard of practice. Looking more at tip location and what can happen when we put it at the right place or don't put it at the right place, we have to review much of the literature that gives us the information on complications. By positioning a catheter at the cavolateral junction, distal SVC, the literature shows us that the thrombosis rate is very low and the rate of dysfunction is low. And so, while there is an occurrence at 1.5% with thrombosis and 0 to 2% with dysfunction, that's pretty low, and we can be assured that this is a safe location. If the catheter tip is higher in the SVC, as in this case the mid-SVC, you can see that dysfunction increases exponentially to approximately 18% with one reference, and thrombosis rises by fourfold to 4.2%. The higher we get in the SVC, the greater the problems and complications. 19% thrombosis, 31% dysfunction in the upper portion or the proximal portion of the superior vena cava. And then when we have positions in the brachiocephalic or innominate veins, you can see that the percentage points are very high, and the possibility of the patient having more severe complications is much greater with this area of malpositioning. And also, if we get into the right atrium, we have more dysfunctional problems. And so the literature supports that the target area for us is cavolateral junction. Our challenge is how to get it there every time. Thinking about clinical applications, how you might use it, different cases that I have reviewed as part of my legal expert witness work, I've tried to provide you with some information about malpractice. In this situation, there was a 10-year-old boy who was receiving long-term medications at home. He had had a PICC line for extended period of time and started having shortness of breath. His physician ordered an X-ray to check for PICC placement, but there was a delay in that X-ray being completed of a few days. When the home care nurse visited the patient and began administering the medication, the patient had increased shortness of breath, anxiety, and cardiac arrest resulted. The cause of this result or reaction by the patient was that the catheter had been positioned in the right atrium for an extended period of time, eroded through the heart wall, and the result was cardiac tamponade. Unfortunately, the patient died en route to the hospital. In this situation, this is one of the most serious results that we could have with any of our central venous catheters. And unfortunately, once it happens, especially if it happens in the home, it's not resolvable. And so our goal is to try and avoid situations like this. And my point is not to create fear and to cause you to have undue concern, but we do have to be completely aware of the complications that can occur and what causes them. Looking at the different forms of confirmation and technology that helps to guide us to the right location, we have research that shows us that by external landmark method, we can position the catheter within the gray zone that you see on this drawing. Once we add magnetic tip navigation, we can get even closer to our target zone, as you can see with the dark purple area. By adding ECG or EKG guidance, we further limit our target area to the lighter purple area and make it more accurate and precise. By adding additional technology such as Doppler, we're able to do better identification of how to get it into the exact area that we're shooting for, our precise and accurate target. There are other factors that cause movement of a catheter, and that movement can result in complications. Even though we position the catheter in the target area, it can move off of that area. But in fact, if we position a catheter tip suboptimally, we even have greater movement. What you see here are some of the factors that affect movement of the terminal tip by position, by movement of the arm, by positioning of the patient. You can see 2 centimeters, 2 to 4 centimeters, or 1 to 2 centimeter movement based on all of these positions that are represented in this diagram. Each movement can cause an increase in risk to the patient, risk of catheter-induced atrial fibrillation or ventricular tachycardia. We can also have other right atrial wall-related complications such as erosion and cardiac tamponade. Irritation from things like nutritional support or total parenteral nutrition can cause more issues that may result in a greater risk of thrombosis. With thrombosis, we know that there's a relationship with infection. And so all of these things point us to the fact that we want to be accurate with our positioning, and we want it to stay there. Now, that may not always be possible, but we do need to be aware of all of these factors. Another case study that I'd like to present to you occurred on a Friday afternoon with a PICC order and placement. The nurse placed the catheter, what she thought was correct, and then the patient went in for an X-ray confirmation. In this case, the radiologist read that the PICC tip was in the internal jugular vein. Then the radiology department closed up. As a small hospital, they didn't have extended hours for their radiology department. And so at this point, the nurse had a decision to make. The choices were to remove the catheter, decide whether access was really needed or if there was another way to provide access, wait for the catheter to drop. Well, in this case, there was no PICC nurse that was available on Saturday or Sunday in order to evaluate the catheter within 24 hours. And it wouldn't be appropriate to leave a catheter in that position over the weekend. She could have also pulled it back to an alternate position, but we know that potassium and some of the other medications the patient was receiving were irritants, and so that wouldn't be appropriate either. Or they could replace the catheter with a new insertion or an exchange. But still, radiology wasn't available for confirmation. In this case, the nurse pulled the catheter back and did not get another X-ray. The result of this situation was that within 24 hours, the patient began having level of consciousness changes. The patient became confused and died within 48 hours. They identified the cause as an arterial placement of a PICC line with the infusion of medications. When the nurse pulled the catheter back, she had cleared the catheter for usage without an X-ray and without confirmation by the radiologist, as was their policy. The reason that I am aware of this case is because I had to review the medical records. The radiologist clearly misread the film because it was arterial placement. But that's quite common. It's very difficult to know that a catheter is in an artery versus a vein, especially if the catheter doesn't pass the sternal notch. The subclavian vein and subclavian artery run very close together, and it's hard to determine which it is in a flat film that only measures one dimension. In this case, the nurse did not follow policy, did not allow for correct confirmation of the placement, and still cleared the line for use. The results were not good for her, unfortunately, as she was suspended, and the case did go to settlement with this particular plaintiff and the family. So the conclusion is we need to follow our policies and procedures, provide for adequate confirmation in keeping with the policies, and also make sure that the catheter is where we want it to be when we conclude that insertion. Prior to clearing any catheter for usage, it must be in the right place. And I recognize that there are many situations that are challenging for us and require us to use good judgment. It's not always easy to make sure it's in the right place. But why do we want to make sure that it's always there? Well, the case that I just discussed underscores the need to make sure that the patient is safe and that more serious complications don't occur, in that case resulting in death. Cardiac arrhythmias can develop. Arterial access can obviously lead to more serious complications. Erosion, thrombosis, pulmonary emboli, and cardiac tamponade are all the most serious complications that can occur from improper terminal tip placement. We have multiple causes of these types of complications, and as you can see, this list is fairly extensive. All types of malpositioning in various locations. We have to recognize that anything other than distal SVC cable atrial is considered suboptimal tip placement. And suboptimal tip placement puts you at risk of greater liability with this patient. If anything happens, if serious complications result, you may be implicated and your hospital. And so we want to put things in the right place because of patient safety and to avoid these various problems and causes. The results for our patients can be a whole list of complications and symptoms that can help us to understand that this is not a good outcome for the patient. We don't want them to have arrhythmias. We don't want them to have infusion into the pleural space. We need to confirm blood return on these catheters and confirm that it is in a vein and not an artery. Keeping the catheter functioning is part of what we're supposed to do in order to provide for their treatment plan. Our goal is to help a patient reach a point of wellness by receiving their complete treatment and help them to go home. We don't want to cause more problems to the patient because of devices that we use. And so understanding all the options for confirmation is part of what our responsibility is in using peripherally inserted central catheters. If we look further at the levels of success that are associated with the different positioning, you can understand why there are liability implications. With a landmark approach, that is visualization or palpation, the success with catheter insertion is about 46 to 75% based on the results in the literature. By adding magnetic navigation, the success rate goes up to 80%, which is much better. And then when we add ECG or EKG, we can reach levels of 55 to 88%, and usually staying in the high 80s, even 90s. The SA node is located near the cable atrial junction and allows the P wave to act like a beacon to guide the catheter down towards the correct location. As that P wave rises, we're able to know what the position of the catheter is. By adding things like Doppler to our EKG, we're able to tell flow and direction of flow so that we can even more precisely identify when we've entered the right atrium or when we're still in the upper portion of the superior vena cava, and even at times when we're going into the azygous veins or other areas. For arterial placement, ECG doesn't give us the best indication, but Doppler does because of flow, and we'll talk a little bit more about that. I strongly encourage you to look at each and every one of these references and to read up on this very interesting subject so that you can validate my findings as well as gain more valuable information to apply to your practice. So what are the liability issues with each of the types of confirmation? Well, simple x-rays is the most common approach. It's the one that's used across the world in order to verify tip position. But radiologists basically use landmarks in the x-ray film to determine where the catheter is. And unfortunately, the interpretation of the landmarks varies from radiologist to radiologist. Frequently, the x-rays are difficult to read because of the resolution of the films, because of the exposure. The lung fields can cause an impact on our ability to see the catheter, and frequently x-rays have to be repeated in order to get a clear visualization of the terminal tip. We also need to look at issues with malpositioning, that even when a radiologist confirms the film, as in our previous case that we discussed, that there can be errors. We have azygous positionings that are unable to be interpreted because of the flat film that we use just as a regular chest x-ray. So frequently catheters have to be readjusted with chest x-rays. When we add ECG confirmation, we get greater accuracy and precision. We're able to see that P wave rise as it approaches and goes through the superior vena cava. And then we gain even more information if depolarization occurs, if we get negative deflections, and understand that we've gone too far and need to come back. Even with ECG, though, we're unable to detect arterial placement because it's based on proximity to the SA node. The sinoatrial node is in close proximity to various areas of the heart, and so even if we're in the artery, we may see P wave changes. With the ECG and Doppler, we're able to gain knowledge of flow. If we're in the artery, we'll see a backward flow and a turbulence reflected in the Doppler image and flow screen. We'll be able to see more information when it's in the vein as we approach the right atrium. And even if you advance into the right atrium, you're able to see clearly that turbulence develops. And so, specific to accuracy and precision, ECG definitely improves accuracy and precision. ECG and Doppler helps us to have more information in order to position that catheter tip in the exact location that we need it. How do we reduce our liability issues and our potential for malpractice? Well, by developing processes and policies within our institutions, by trialing different technologies, by seeing what works best with our patient populations, we can help to promote more consistent outcomes and gain terminal tip position in the exact proper placement 95% of the time. We want also to have confirmation in a timely manner. I know in my practice, I celebrated when we were able to stop using X-ray and go strictly to confirmation at the bedside during insertion. By using these forms of technology, we were able to confirm and clear the catheters for usage, allowing the bedside staff to immediately institute the treatment plan without delay. This was awesome. Works really well, saves us so much time, and also makes the rest of the medical and nursing staff very happy. They were all cheering with us. And so we have many different forms of confirmation, but that doesn't mean that we can only use one. There are certainly times when we need to get X-ray confirmation if there's any question about the position of the catheter, if the patient has arrhythmias or other types of problems. My rule of thumb is if I'm not comfortable with it, if anything seems wrong, I'll get an X-ray to confirm the location. Doppler provides us with more information. Just like we started with ultrasound and began identifying vessels and using needle guidance in order to gain greater success, over time our ultrasound resolution has improved, our ultrasound functions have improved, and the same applies to the technology that helps us to position these catheters. By adding additional technology like Doppler, we're able to see flow signatures that shows systolic flow, diastolic flow, be able to see the pulsatile rhythms that are normal within our vessels. We're also able to see, and this is an image that comes from TEE, transesophageal electrocardiogram, that shows a sinus rhythm, how in the right atrium the blood flows away from the transducer, we get an antegrade flow, and then the blood flowing towards the transducer is the part that is below the line, and retrograde flow. So we're able to see that there is turbulence generated with a back and forth flow signature. We can see some of this in conjunction with the ECG rhythm in order to help us to interpret where exactly we are. Here's a depiction of the Doppler flow signatures at various points along the innominate, brachiocephalic, and superior vena cava locations. You can see with the bottom one in the right atrium that you have much more activity and turbulence, more retrograde flow, which is below the line, showing that there's movement backward. Whereas at the cavolateral junction, you do have more movement above, or antegrade flow, which is forward. And so by learning to interpret these signatures, we gain more vital information that helps us to be more precise and accurate. Catheter tip position is necessary in a particular zone in order for us to reduce complications adequately, reduce risk to our patients. The best zone for the patient, as you can see from this drawing, is in the blue zone. This area helps us to reduce complications by the greatest percentage, and also helps us to avoid positioning within the right atrium by applying our technology, by knowing where exactly the catheter is by using ECG and Doppler and looking for balanced flow signatures. One of the things that I wanted to add to this is when I'm doing catheter insertions, I may get all the information that I need to know that I'm in exactly the right place immediately, but I still spend a little bit of time moving back and forth to confirm to myself that I am exactly in the right place. I want to make sure that I reach my maximum P wave, that I don't have any negative deflections, that the flow signature and everything is working perfectly, just to give myself peace of mind that everything is perfect. And so I may move backwards by 1 or 2 centimeters, I may move forward slightly, and confirm that I have my maximum P and everything is lining up well. So how do you apply this information? How do you get this technology and apply these processes within your facility? The first step is really to gain support. You need to get some people on your side and supportive of the technology that you need in order to become more precise and add safety for your patients. Overall, this type of positioning or confirmation does help to save time and cost for the patient and facility, and helps us to use the device sooner. With this type of process, you need to gain the support of various people such as your director, your manager, other medical providers, physicians, and provide them with the articles and information, some of which I've shown you here. They need to be clear on what it does and how it works. I think it's very interesting that I have physicians that stop me in the halls and ask me about tip confirmation and what we're doing. They are so interested and want me to fill them in. But more importantly, I offer to send them some of the research and articles that talk about the process because I want them to have full, complete information. So after you gain the information and get the support, you want to make sure that they understand well, they understand the value of these processes and how it can impact the patient. Improving processes is really what we're all about. None of us want to be stagnant. We want to reach our 0 points with infection prevention. We want to make things safer for our patients overall. We want to improve efficiency. And so how do you do that? Well, you'll need to create policies and procedures and do a trial with this process. Work together with your hospital, your risk managers, and your other people who are involved in this process and establish a number that you need to have for correlation with X-ray and with your technology in order to gain tip position. Set up a specific number rather than a time frame. It works so much better. And I strongly encourage you to work together closely with your radiology department so that they know exactly what you're doing. By keeping them informed, you can work together and get better correlation to make sure that your trial goes smoother. That worked really well for us and was so important. And so if you set up to do a certain number of placements and you gain your correlation level at whatever percentage the hospital requires, then you can move on to apply your policies to send the information through your medical staff or your medical review boards in order to gain acceptance and clearance to be able to use the devices with these types of confirmation. The whole process doesn't take any time at all depending upon the number of catheters that you insert per week or per month. We always want to do safety checks too, as I mentioned, that anytime you don't get a clear correlation or you don't get a clear notification that the P wave is correct, that the Doppler signature is right, then those are times when we need to use X-ray to confirm the location. Anytime I have a question, anytime things don't seem right, I always order an X-ray. Most importantly, for liability reduction is documentation. If you have a problem with the position of a patient's catheter, then you need to document why you left it in that place. You need to document what you did and why. These things are very important to show that you had a clear understanding of the processes and the risks to the patient. So accuracy, precision, and safety. Do you consider any of these optional? We all want to be accurate. We all want to be precise. But joining these two together helps to equal safety for our patients. We want to have the greatest reduction in tip malpositions, gain the greatest accuracy and precision, and also minimize our liability. But the most important thing for all of us is to safeguard our patients, to position it right the first time. The technologies such as ECG and Doppler help us to achieve that goal and to reach a safe position with all of our devices. I thank you for your attention with this presentation and welcome your questions. This is a continuing education program, and so at the end of this webinar you do gain 1 contact hour. You will need to go to the website, and I recommend that you write it down. You see it listed here. You'll also receive an email at the conclusion to tell you where to go. You'll need to complete the post-test and the evaluation form. After you've completed these submissions, you'll receive a certificate of completion that you can print out. I strongly encourage you to provide a copy of this to your employer because keeping things like this in your employee file is part of reducing your liability. Many thanks to Emily and Sharon at Sachs Communications and for their provision of our continuing education credits through the California Board of Registered Nursing. Also thanks to Teleflex as a sponsor of this program. Thank you to Teleflex for promoting education such as this. Rita, I know you have many questions that you would like for us to discuss. So at this point in time, I give you the ball.
Well, thank you, Nancy. That was a great presentation. I hope that we all learned something. Our first question comes from Mary Ann, and it is a question that many nurses have had to deal with at some time or another in their careers or at their hospital. So I think it's very timely. And Mary Ann states, at my hospital, a group of MDs have us pull back the PICC, even if it's at the SVC-RA junction. We have tried to educate them, but to no avail. Any suggestions to help us change this practice when the PICC is at the right location and they have us pull back?
Oh, thank you so much for this question. Doesn't it happen all the time? I certainly see it in my practice frequently, and it more so before when we were doing x-rays. But even now when we get rechecks or we have patients that they have questionable locations, the suggestion that I have to you is again to work closely with radiology. You've said that you've talked to them, you've provided them with literature. That's certainly all that I would recommend. But if I were to say one more thing, it would probably be to see if you couldn't get one of them to come and watch an insertion. If they could see you in action and see how you're using the technology and how it shows you how to position the catheter in the right place, I think that you would gain a lot of support and understanding by radiology. I know that I've had various physicians watch me during insertions, and they are just astounded at how the P-wave can show us exactly where to go, exactly where the location is, and the positioning with the Doppler signature as well. And so, you know, gaining support and understanding is tough for all of us because radiology has their one room that they're stuck in and they're reading these films, and that film gives them a limited amount of information. So I do encourage you to share the research with them, but more importantly, maybe see if they'd be interested in shadowing you or give them the opportunity to observe an insertion and see if it doesn't change things. I really admire teams that work together with their radiology departments and even have lunches or spend time with them discussing some of the issues. And while time is a valuable commodity for all of us and we don't frequently have those opportunities, it's nice to consider, and even the opportunity to do education within the radiology department may be helpful. I hope that answers your question.
Very thorough answer, Nancy. Nancy, next question. Do you suggest that an X-ray be done whenever you adjust the PICC less than 3 centimeters?
The short answer to that is anytime the PICC is moved, it should have an X-ray to confirm the last location. I gave you an example of a bad scenario where a nurse pulled back a PICC line and did not get an X-ray. I can tell you that that was probably one of the worst days in her life because not only did it come back to bite her, but she very well lost her job over the situation. And it was because she didn't get an X-ray. And there were so many other variables there that created a problem for her. But I can say that in all my medical reviews, the last X-ray needs to be the correct one. If you have an x-ray on the books that says it's in the wrong location and nothing else to follow it up, then no one knows what you did. Yes, you may have documented it, and that is helpful, but the last x-ray needs to be the correct one from a liability point of view. Always recheck it, even when it's just a smidge.
Okay, good information, thanks. And from Holly, when you using the blue bullseye technology, does it make it safer with a patient with a high INR? And what would you say are acceptable ranges to place a PICC with INRs?
Okay, well, you have two different issues here. I mean, the INR is really focused on the risk to the patient in bleeding with insertion and not necessarily with terminal tip placement. The blue bullseye or the technology used to position the catheter can certainly provide a degree of safety for the patient in that you don't have to manipulate the catheter, in that there's no added trauma to the patient. You go in smooth and easy, you position the catheter correctly, and then you can apply whatever dressing is indicated for the patient. But specific to PICCs and INRs, there basically is no restriction on INR levels. That's not to say that you shouldn't be aware of the patient INRs and their risk of bleeding, but a PICC is actually indicated for patients that have the great risk of bleeding, because other central venous catheters would not be indicated. So in fact, peripheral placement gives you the opportunity to apply direct pressure. It allows you to control any bleeding so much better than any other central venous catheter placement. And so it's very rare that I see any policy and procedure with PICC lines that contraindicates PICC placement due to INR levels or PT or PTTs, because truly there are no restrictions for PICCs. You're using visualization, hopefully, with ultrasound. That would be indicated for a bleeder. You're following the needle end, and you're doing the insertion as carefully and safely as possible. That's the best that you can do, but it wouldn't be contraindicated with any INR level, no matter how high.
Okay, thank you. Nancy, from Chris, does this device work in pediatric patients or patients with no P wave? And we're talking about the ECG and Doppler combination.
Okay, so let's talk about no P wave first. The technologies that we have available, ECG, will not work without a P wave. We have to have some ability to see change in the P wave as it approaches the right atrium. And so without a P wave, we can't do it. If you add Doppler, depending upon your level of skill, because it does require interpretation, you may be able to get positioning based on the Doppler signature alone. Even then, though, I would still send the patient out or have x-ray done at the bedside in order to confirm that you're in the right place. So in fact, it can help. There may be a learning curve involved for you to interpret the signatures correctly, and there's a little variation from patient to patient. Now, as far as pediatric patients go, that's kind of still out there. There's not been any testing done in the pediatric population or neonatal population, and it's my understanding that there are some differences in the heart electrical activity that cause some issues for pediatric patients. And so I'm going to not give you a whole lot of information because there's just not a lot available yet. And so no, the technology is not being used with peds yet. If you're interested in doing a trial with pediatric patients and this technology, I encourage you to contact the manufacturer and see what can be worked out, because we would all like to see the results of a study like that.
Okay, thank you, Nancy. Nancy, I'm going to combine two questions into one because they're both talking about midlines. First is a follow-up to a previous question when it was asked about pulling back the X-ray and pulling back the PICC and re-verifying with an X-ray. You recommended that it be done so the last placement is charted. So we ask then, would you also recommend then an X-ray if you've pulled the PICC back to a midline? And in combination with that, what's the risk of thrombosis for a midline?
That's a lot of questions. Okay, so if you move the catheter back to midline, midlines do not require X-ray. And so no, you would not need to get confirmation for a midline position catheter. My opinion is that it may be questionable where you pull it back to, and sometimes I'd like to know, but based on the standards of practice, we don't need to get a follow-up X-ray for a catheter that is placed in what we consider to be the position of the midline. So where is the midline tip position? Well, the midline tip position needs to be below the shoulder. The catheter should not advance into the chest. It should be in the upper arm, and so we would need to pull it back far enough to achieve that position. If we don't, then the risk of thrombosis is very high. There are plenty of published studies that talk about the risk of thrombosis in the subclavian area, and there has been legal precedent set, multi-million-dollar legal precedent set, that says that you should not leave the terminal tip in the subclavian vein. And so even though you pull back, please assure yourself that it is far enough back. So the other part of that question was, what is the thrombosis risk with midline catheters? I have always felt that the thrombosis risk with positioning in the upper arm was much higher. The research that I have seen recently does not support that. I am an old dog, but I can learn new tricks. And there are times when I have to reconsider my position based on the evidence that's available. And so the evidence that we're starting to see by Anderson and a number of authors where they've done their studies clearly shows that midline catheters and even ultrasound-guided peripheral catheters, longer length peripherals, are doing much better and have a very low rate of thrombosis. I think it really focuses on what we put through them. The worst scenario is with a highly osmotic solution. If you have a very concentrated or irritating solution going through, your risk of thrombosis is much higher. Rita, did I miss anything?
No, thank you very much. You did great.
Okay,
that was a long question. Next question. Do you need a chest X-ray then to verify tip placement after you've placed a catheter with Doppler and ECG technology to get verification then?
Well, the short answer to that is no, if everything was correct within the manufacturer's recommendations for confirmation. And of course that sounds like a bit of mumbo jumbo, but it's hard to say, okay, with this one it's this one and this one is this one. So there's some variations. But the long answer is it really depends on your policy, doesn't it? If you haven't established a policy that says that you can clear the line for use after using this technology confirmation, then you still need an X-ray. I know we ended up spending like 8 months waiting for our medical staff review to approve our process and clearance without X-ray. And so during that time, we had to continue to do X-rays on every catheter placement. So you can imagine why we celebrated at the point that we got clearance. But you don't need to do an X-ray based on the manufacturer's recommendations if you have achieved the bullseye or if you have achieved the maximum P wave based on the instructions for use with the device.
Okay, thank you. We have approximately 5 minutes left, so this will be the last question.
Rita, can
Yes,
I make just one comment? I noticed
absolutely.
that on the questions that someone was asking for a reference for the no INR restriction. And that kind of goes back to when you don't have to have it, there's no reference. So I would have to say there is no reference for the no INR restriction, but you can see very clearly within indications for PICC lines that patients with coagulation disorders are frequently on as an indication. And while it may be listed as a contraindication, it's simply because of higher risk to the patient. And so there's no reference that says you don't have to do this. If you follow what I'm saying, there are no references to say that things aren't necessary. We simply have evidence and references to say that you must do this or you must do that. And so I can't really help you with that. It's just not there. My validation would be to say, look at other policies of other institutions and see how they're doing it. And talk to your risk managers. Go ahead, Rita.
Okay, thanks, Nancy. Last question. We've been hearing a lot about arterial placements. Why can't clinicians always tell when they poke the vein by the color of the blood or the blood flow? And why aren't x-rays reliable for confirming this in the artery?
Well, this is a great question and one I get all the time because it seems like it would be so obvious. And having experience with arterial placement or arterial access and placement, both with my insertion as well as observing others, it's just not that easy. You look at the different factors to help to validate, is it in the vein, is it in the artery? For all of those that are on the webinar today, how many of you have accessed a vein with a very strong flow? I'm sure all of you have. How do you know it wasn't an artery? Well, you start adding it up. So think about the 5 P's. The first P is paresthesia. They may have numbness or irritation in the lower arm. They feel pins and needles. The next one is pulsation. You expect to see a very strong flow or pulsation. Even if you thread the whole catheter in, you should see pulsation within the tubing as a validation that it's in the wrong place. Hopefully you'd never get to that point. So you have paresthesia, you have pulsation, you also have pink. So you expect it to be bright colored. I have inserted on a patient in the ICU before where their oxygenation levels were terrible and their blood was very dark. You couldn't tell. It just wasn't possible. But you still look for that as a factor. You also look for pallor. They may have blanching or whiteness in their arm because of the nerve supply to the artery. And then lastly, pain. Any patient that continues to have pain at the insertion site after you've removed the needle, after you've started inserting the catheter, and even after you've finished, is suspect for either arterial placement or nerve impingement. Both of those are highly litigated situations, and so likely you'll need to pull either one of them. So continue to validate with the patient. Does it still hurt? Does it still hurt? Describe for me what it feels like. Because in both of those situations, you have a potential for injury to the patient over time. And so looking at arterial placement, you have to add up all the factors. Now, how does the technology help us? Well, especially with Doppler, we're able to see directional flow. Once I start inserting the catheter, the Doppler tells me if the flow is going in the direction of my insertion. If I get retrograde flow, or if it turns backwards and the flow is against my catheter, then something's wrong, and I know that that's potentially an arterial placement. Now, will technology help you avoid completely inserting into an artery? Well, nothing will do that except trying to be careful with how we use our needles. And as we insert deeper and deeper and use more veins, the risk of arterial placement has actually increased. Even though we have ultrasound, even though we know what we're looking at, there are times when we may accidentally access an artery. This is not a problem as long as you identify it early, apply pressure for a period of time to make sure that coagulation occurs, and then move on to place the PICC in another area. I then alert the bedside staff to do follow-up checks at least every 15 minutes for an hour, just to make sure that there's no additional bleeding occurring. And of course, I would put a pressure dressing on the site. But arterial placement is a fact of life. It will occur sometime within your career if you're doing enough insertions. But understanding how to validate if it's an arterial placement is just adding up the 5 P's and using technology that's available to you.
And thank you very much, Nancy. That was great. That is a wealth of information for those of us who've put in PICCs for years. We've seen the process and the standards change over the years. I take the first question from Denise. And Denise, I'm going to paraphrase just a little bit. We've all had patients like this. You're trying to put in a PICC, and you're running into many, many complications and roadblocks getting the PICC into the SVC. And either the proximal SVC or the mid SVC is where we have to leave it. And the chances of course, trying to get it, to redo it and get it in again is very low. So what are the risks if we leave it there? And is this better than no line at all?
Well, Denise, that's a very good question and one that we've all had to face. Part of reducing liability is documenting why the risk-benefit ratio tells us that it's important to leave it in that location. So, for example, if you have a catheter that is in the midsection or proximal superior vena cava, and you have exhausted all possibilities for gaining the best access, which is distal SVC caval atrial. If the patient has no other options for vascular access, then it may be necessary for you to leave it there. The scenarios that I can think of are the patient is in a critical state. You've already manipulated the catheter enough. Radiology is unable to reposition for whatever reason, and you have to leave it there. Just know that the risk of thrombosis is higher, as I outlined in this presentation, and you should document that you provided education to the nursing staff for signs and symptoms of what to look for. That you should talk with the physician and work collaboratively so that you all understand what the risk is in leaving this catheter in this position. If any symptoms develop, you want to be alerted right away so that the catheter can be replaced or resolved in whatever situation that occurs. In some cases, especially when it's in a proximal or the high position of the SVC or even brachiocephalic, the best position for this patient is midline. If you leave the catheter in the high position where I showed you that the rates of thrombosis are 45, 70% or even higher, then we know that's going to happen. And so by pulling the catheter back into midline, you may limit the drugs or medications that can be infused, but you also reduce the complications that may develop. I can't really say I have a perfect answer for you because unfortunately this one is one that requires a lot of judgment, a lot of decision making as far as the risk-benefit ratio for each individual patient, and there's not an easy answer. I hope that this one helped.
Thank you, Nancy. And this question from Bill. We've been hearing a lot lately about arterial placements. Why can't clinicians always tell when they first poke the vein? How about the color of the blood or the blood flow? And you said that x-rays are not always reliable for confirming placement in an artery. Explain that to us, please.
Okay. And those are reasonable questions, especially if you've never hit an artery before. Because truly it seems like it would be obvious, doesn't it? It seems like, or I once heard a deposition by a nurse who said it couldn't have been an artery because when I pulled the introducer out, the blood didn't hit the wall. And all patients do not have strong arterial pressures. All patients do not have bright red blood or good oxygenation in their arterial blood. All patients don't have the same symptoms all the time. And so I have been involved with 3 arterial placements, one of which was threaded quite a long way. Each time there was some intuition that this wasn't quite right, but all of the symptoms didn't line up. I consider arterial placement differentiation based on the 5 P's, and all 5 P's may not be present. Let's see if I can give you all of them. The first P is pulsation. The second P is paresthesia, where they have numbness or tingling, especially in the lower arm. The third P is pink, because typically we're looking for a lighter color to the blood. But I can tell you, when we're using different colored drapes, it's really hard to differentiate that. So we have pulse, paresthesia, pink. There may be pallor or white blanching in the extremity because of the nerve impingement. And the last P, which people frequently don't know or don't realize, is pain. So if you have a patient who is complaining of pain after you have removed the needle, after you have begun threading the catheter, then this is a big red flag. It is one of 2 things, both of which create a great liability for you. It could be either an arterial access, or you've impinged upon a nerve, and a pretty good sized nerve such as the median nerve, which is in our area of insertion. And so pain is a really strong sign for us to look for and one to evaluate. Now, the second part of your question focused on why it's not really clear on the x-ray when it's an arterial placement. And with that, I'm going to tell you some things, and you're just going to have to trust me. But I encourage you to try and find some x-rays that are arterial placement so that you can see it. So what the deal is with an x-ray is it's a flat film. It's 1D. You can only see from front to back. So when you take a picture of a patient, you simply see the catheter overlying an area. Depending upon how the patient is positioned, whether they're flat or whether they're slightly turned and oblique to the right or to the left, this can affect where the catheter overlies. One of the hallmark things we look for with an arterial placed catheter is that it crosses the midline. We know that the superior vena cava is to the right of the sternum. And so if a right-sided placement crosses the midline, then something's wrong. It's either an arterial placement or it has crossed over in the innominate brachiocephalic vein and is crossing over to the other side. But an arterial placement is more likely to be a bit of a loop or an arched crossing. If you're oblique or if your patient is turned just right, it will never cross the midline. I've seen many arterial placements with neonates where they were not able to tell. You also have much more difficulty in telling arterial placement if the catheter is not advanced past the sternal notch, because the subclavian vein and artery run together. They're in very close proximity, and so you can't really differentiate which one the catheter is in, because flat film x-rays don't really show you vessels. They show you bone and tissue. And so you're looking at the catheter without the benefit of seeing the actual vein walls. And so I encourage you to do a little more study, to take the opportunity to look at more films and see what it is that I'm talking about. Ask some radiologists why it's difficult. And they may say, oh, it's not difficult at all. Well, it is. And frequently it's missed, which I see in legal cases. I hope that answers your question.
Thank you, Nancy. David asks, does the vessel that a PICC is placed into factor into tip movement up or down and body position for proper tip placement?
You know, that's an excellent question, because that's absolutely true. So let's look at it from two different points. If we insert into the cephalic vein, you will have more movement of the catheter tip. If it's inserted into the basilic vein, but inserted from the left side, then the catheter may move more, simply based on the length of the catheter and the path that it takes. And so with those types of differentiations, you can have more movement. With neonates or pediatric patients that may have catheters inserted from postauricular veins or other veins, these won't have as much movement as we have from the arm. The arm in and of itself results in a lot of movement of the catheter. And so that's kind of it in a nutshell. There are a couple of posters that were presented, one by Holly Hess that talked about movement of a catheter, and I think that that one is published. I know that I have another article that was published on catheter movement associated with the arm, not necessarily with the vein. So maybe that's something that you might like to study and publish on. Thank you for asking.
Thank you, Nancy. Another great question here. May wants to know, how much Doppler knowledge is needed to use the technology along with the ECG?
Well, May, I think we learn so much over time. You know, there is a bit of a learning curve associated with all of these forms of technology, and not necessarily a whole lot of specific education that is available to go along with it quite yet. The longer we have technologies, the more information that's available. And so in answer to your question, I'd say that there is not a whole lot of information that you need to know in order to use Doppler technology, but some of it you'll gain over time simply by your ability to identify the flow patterns and see how it works as you're doing advancement of the catheter. There is education that's available through the manufacturers, certainly on ECG as well as Doppler, and they provide you with as much as possible to get you started. But as I said, I think that we'll gain so much more over time, and we just need to start. Plus, we need more and more people to study it with a vascular access focus so that we all can benefit from the information and the education. And so maybe you'll continue to do that.
Thank you, Nancy. We've got about 5 minutes left. So Kitty asks, should patients who have atrial fib and have a PICC inserted by the ECG and Doppler technology, do they still need a chest x-ray?
The answer to that, the short answer is yes. The manufacturers that provide these technologies all state that if atrial fibrillation or other cardiac arrhythmias are present that may interfere with the P-wave interpretation are present, that an x-ray placement, an x-ray confirmation is recommended. In my experience, and this is simply my opinion, if I'm able to see a change in the P wave, a significant change that shows me advancement, and I can correlate it with movement of the catheter tip, then I may be able to confirm that catheter in the tip location that I want, a cable-atrial junction, simply by my own interpretation. And again, just like we were talking about with Doppler, we learn so much over time, and as we get better and better with the technology, we may find ways to work with certain patients. But it's hard for me to say this is specific to all the devices because there are some variations, and we have to be aware that anytime there are arrhythmias present, that this can interfere with the confirmation by this method, and that for safety's sake, we should get an X-ray to confirm that everything's good.
Okay, thank you, Nancy. Christina from Methodist Hospital also has a question. If the tip is at the CAJ and the radiologist asks you to pull it back, what is the best approach to handle this?
Oh, that's tough, isn't it? And I can say that everybody that has transitioned into ECG has had this problem at one time or another. You know, that's a toughie that I like to discuss face-to-face with individuals, because you go, well, what I do is, in my situation at our hospital, when we have situations where the radiologist says one thing and we know another, we go ahead and make a pullback. We may not pull it back the total amount that the radiologist recommended, but we always do another X-ray check in order to confirm it's in the right place. There are times when we've had to pull back a couple of times, and in these situations, it's now, because we're using this confirmation all the time, it's mostly with our AFib or our arrhythmia patients. And so it just depends. It's also really good, as I said in the presentation, to coordinate with your radiologist, to let them know what you're doing, especially as you start your trial. Because it wasn't until we actually started talking with our radiologist that it started clicking better. And what I mean by that is we started our trial and we were getting a lot of pullback comments from our radiologist. And with an X-ray, they look for landmarks, and different radiologists interpret those landmarks in various ways. And so one radiologist may read things one way and another one read it another. So when we let them know that we were using this technology, they became more comfortable and the correlations got better. And so all I can tell you is work with them, pull back when you have to, but always, always get another confirmation in that situation, because your last report needs to be correct from a liability point of view.
So Danielle asks a very good question. I work with someone who continually will pull back a power pick as a midline and leave it. I was taught that power picks are indicated for central location only and should be replaced as soon as possible. What are your thoughts?
Okay, so that's a tough one. Number one, you're dealing with a brand, and number two, you're kind of edging on a policy issue here. Specific to the type of catheter that you're using, yes, you need to follow the manufacturer's recommendations. Every manufacturer has some slightly different recommendations as it applies to midline catheters. Pulling a catheter back to the midline level is something none of us really want to do. We all want to be in the exact right location. We don't want to have 15 or 20 centimeters hanging out of the patient, because we know that it creates a greater problem. And so there's no good result here. You're specifically talking about a colleague who is doing something that you don't agree with, but they're maintaining access. As we talked about with one of the first questions, it's a patient-by-patient decision. If a patient is in a critical situation, if the patient needs access and everything else has been tried, then you may be stuck with pulling it back to midline, because for various other reasons you may not have been able to gain the correct location in the superior vena cava. Your question is this acceptable? I can't speak to the brand and their recommendation, but I can say that this is done on a regular basis. My preference is if I'm unable to gain access with the PICC line, I would prefer not to leave it in a midline situation if the medications do not warrant a midline. I am more likely to try and insert an ultrasound-guided peripheral and give them access, and then potentially try the PICC from the other side. But again, it's a patient-by-patient decision. It's one that you have to determine with each case. And developing policies and procedures on midlines is also important, and one that I think many of us are getting into in a stronger way. Midlines are coming back. They were very popular 20 years ago, and we're now seeing a new influx of midline catheters. Of course, when using a midline catheter, we should use a product that is manufactured for that purpose and for that indication. Some manufacturers of PICC lines do not recommend that you trim their catheters to midline, and so again I refer you to the manufacturer's recommendations. But there's no good answer for you. Is this something that we want to do, pull the catheter back consistently to midline? No, it's not. Is there a better way? In some cases, no. In other cases, you may be able to work with an ultrasound-guided peripheral or be able to try from the other side. I know that I tend to be a more persistent inserter. It may be that I just always want to be successful, and so I try and try and try. But there's a point at which you should stop also and just give the patient access and go from there. So I can't remember the last time I pulled a PICC back to midline, but it happens. And so that's the best I can do for you. Sorry.
Thank you. That's a complicated question. This from Jerry. An interesting situation if you have a looped PICC, but the tip of the catheter is in the distal SVC-CAJ. What are your thoughts?
Isn't that interesting? I've seen that happen recently. It's a tough one. What do you do? Well, you have correct position. So, in fact, they can use it. We had one do that not too long ago. We would prefer to have the catheter drop down and not looped. And so what we did over a period of a couple of days was do some arm manipulations. We talked about movement with arms. And so if you follow some of the arm adjustment recommendations that you can find in some of the articles, or even the table that I showed you that showed arm movement, you may be able to get that loop to drop. Can you use the catheter? Well, as long as it's in the correct position for the terminal tip, is that loop acceptable? I'm going to refer that back to your policies and procedures, because that's a tough one and not one that I can just answer across the board. But my preference would be for radiology to position it by inserting a wire and straightening it out and get it in the right place. My second choice would be arm manipulations to try and drop that loop. I don't want to have too many x-rays because I am concerned about patient exposure to radiation. And so ideally, it'd be nice to have radiology take care of it. but it's a tough one. You can use it, but that loop has to have some assessment on a daily basis to make sure that it has not dropped down and your catheter is not into the right atrium or even right ventricle. Good luck with that one.
Thank you, Nancy. An interesting situation. Another question from Martina. She wants to know, how does the P wave change if the tip is optimally placed at the CAJ?
Well, I'm not quite sure what you're asking there, but let me answer in simple form what I think you're asking. So what we're looking for with a P wave change is P wave elevation. If you're able to compare external EKG monitor, the rhythm on the external patient in comparison with the internal rhythm, then you're able to see the P wave elevate as it enters the superior vena cava. As it advances through the superior vena cava, the P wave will continue to elevate. Your goal is to find maximum elevation without a negative deflection. And so when the catheter tip reaches the caval atrial junction, you should be at its max. We used to say that it would be equal to the QRS complex in its height, but we now know that that is not true and that there's a lot of variation. So we're simply looking for max P, and that shows distal SVC caval atrial. If you start to see negative deflection below the line, which represents depolarization, then you know that you've entered the right atrium and are either at the SA node or passing the SA node. And so I do minor adjustments back and forth, nice slow adjustments. Even if I have a very clear indication immediately that I'm in the right place, it looks like max, I will go in a bit, come out a bit, make some adjustments just to validate for myself that the positioning is where I want it. And while I may not always have excess catheter to advance in a little bit more, my adjustments help to assure me that I am at the cavolateral junction based on maximum P wave and lack of negative deflection. I hope that's what you were asking.
Thank you, Nancy. Emily, we're going to turn this back to you.
Okay, I would like to thank you very much for your time, Rita and Nancy. The material that you've covered with us today is vitally important to the care of patients requiring PICC lines, and we've all learned quite a bit. Finally, and last but not least, I would like to thank each and every one of you, our guests in the audience this afternoon, for your time and thoughtful attention. And with that, it is time for us to say farewell. Take care, and bye for now.
Bye.
Bye-bye. Thank you.